Hello, friends. Good evening. So, welcome you again for yet another fascinating session of IAB Basic Bronchoscopy Certification course. So, we all know that it contains 12 online modules and one hands on workshop, and you need to be present at least for 10 out of the 12 modules and attend one hands on workshop for getting the certification. So, today we have a very interesting topic, the conventional TBNA, which is something which is still not forgotten and still quite useful, especially when you don't have an access to an e-bus. And along with that, we'll be having the discussion on foreign body removal. So we have esteemed speaker as well as a great set of panelists. On the first go, I'll introduce our first speaker of the day, Dr. Samir Bansal. He needs no introduction, a very good friend of mine and an excellent interventional pulmonologist coming from Bangalore. He's a senior consultant, pulmonary and critical care and interventional pulmonology at Apollo Hospitals, Bangalore, associate professor at Apollo Health, senior consultant and clinical head, Vayu chest and sleep specialist. And they have set up the Vayu Center of Excellence for Asthma and ILD with international collaboration. Also set up the lung transplantation program at Apollo Bangalore, runs a non-profit NGO for social economic learning, social emotional learning in early childhood education, editorial members of numerous publications with more than 45 publications and 5 book chapters in national and international journals, member of reputed interventional pulmonology and respiratory forums across the world, and speaker at various national and international forums with special areas of interest involving asthma, COPD, and ILD. So today we have Samir with us to give us talk on TBNA and foreign body removal step by step, which will then be followed by a panel discussion and followed by that question and answer. Over to you, Dr. Samir, for your talk on the TBNA and foreign body removal.
Thanks, Vishwesh, and thank you, IAB, for the introduction and arranging this particular session. I know it's quite fascinating topic as well. In fact, possibly, when we were also students, so we used to look forward and we started doing conventional TBNAs and all, just by reading and, browsing the internet on how to go about it. So without much further ado, I'll just start off with the topic, conventional TBNA. Yes, I do believe, okay, the time may be a little limitation, but what we will talk about is not indications, contraindications, when to do it and all, but rather the practical details on how to go about doing it. A lot of people are doing EBUS nowadays and EBUS guided TBNAs. What we are specifically talking about is conventional, that is when you don't have any vision, how to go ahead and do it. So when we do this, this is one of the most important things everyone has to know, which is your applied anatomy. So Wang introduced this, and this is something which is very important, the Wang nodal map. As you can see over here, this gives a view of your trachea and the left and right main bronchi at the carina with the major vasculatures. You can see the pulmonary trunk over there, the aorta towards the left, and when you see on the right from 1 o'clock position, there's a superior vena cava, the azygous vein, and in between lie all your nodes. And the figure to your left, to your right, sorry, on the screen shows your nodes with relation to these vessels. Why is this important? Now, it is important to understand that when you do this conventional TBNA, you are blinded. You are going across or your trachea, your bronchi, not knowing what exactly lies over there. So having some knowledge of what vessels, what nodes will give you a fair idea, fair degree of confidence that, okay, you're not inadvertently going to hit a vessel over there. So again, not talking much about this, but granulomatous diseases, malignancy diagnosis and staging and lymphomas is something which is important indication for TBNAs. It's important to think about, okay, what would be the sedation my patient requires and what conduit should I use? Uh, Generally it's GA, conscious sedation, or you can just go under, local, say with lignocaine and nebulizations or some lignocaine sprays and all, which we typically used to do quite some time back. It also depends on a lot of factors, any respiratory comorbidities or any other comorbidities rather, whether you have an obese patient or not, is my patient hypoxic or not, how much time would my procedure take. If you feel that procedure may take a long time, maybe you can go for a better sedation, a deeper sedation plane, and accordingly you can select the conduit, which may be either an LMA. If a patient is already intubated, you can go ahead and do it via your endotracheal tubes also, or you can just perform it, if conscious sedation, via oronasal route, or when you have conscious sedation as well. Important is to see the CT scan, pay meticulous attention and towards all the mediastinal lymph node. This is very, very important as a first step. Why? Because if you're planning a procedure, you have to know that, how big are my nodes, where exactly do they are placed. For example, my 4R lymph node, which is the paratracheal, sometimes that 4R lymph node may be a little, anteriorly placed. In some cases, the 4R lymph node may be a little laterally placed and extending all the way towards posterior. So that is very, very important, so that even though conventionally it may be just paratracheal, the position may vary person to person. Check for FDG uptake, especially if you're suspecting malignancies. Which are the nodes which you need to sample? It should not be that, okay, there is a very faint uptake in maybe one of your nodes, which is easy to sample, and there is a very, very intense uptake in some other node, and you decide to go ahead one sample and it is negative, and you say it's negative, it's negative for malignancy. So that's something which is false negative possibly. So that is important to know. Check for additional clues like vascularities, whether it is infiltrating endobronchially or not, whether there is calcification, because in those cases also your needle may not really penetrate the node if there is a lot of calcification, and any other features is very important to know. So first tip is what to sample. Now, typically 4, 7, and 4R, which is your subcarinal and the right paratracheal lymph node, they have higher yield as compared to 4L, which is your left paratracheal. Subcarinal, generally, when you're doing a conventional TBNA, is the easiest and the most commonly sampled node. And this is because of the anatomical landmark of your carina being there. 4R can be sampled, but have caution, because around there are two vessels, the SVC, which is below the 4R lymph node, and there is the ascending aorta, which is typically around that, 11 o'clock, 12 o'clock position out there. So be careful about those particular vessels. Hilar lymph nodes should be sampled with extreme, extreme caution. One, because there are a lot of vessels around it. So unless you have some other, tools such as maybe a fluoroscopy, or the node is significantly large, always express caution and maybe not do it if you're doing it conventionally, and maybe refer for an EBUS if these are small nodes which need to be sampled. Step two is always setting up the equipment, preparing the needle. Always look at the packaging first, whether your needle, all the parts are available or not. Make sure you lock the needle inside the sheath before inserting it into the scope. Test the deployment mechanism outside, flush the channel with saline and air, and make sure to retract the needle completely inside the sheath before entering the scope. So just as a schematic, this is how it looks like. This is a classical Wang's needle. You can see the parts. This is the sheath out there, and this is the needle out of the sheath. As you can see over here, this on top is the stillet, which you initially agitate and take out to remove all the contaminant material. This is the channel for flushing. And once you remove the stillet, you can apply your suction over here, and this essentially denotes the same thing. How to prepare the scope? Once you insert the TBNA needle through the working channel, keep the needle fully sheathed at all times till the time it is inside the scope. You advance the scope to the target side, and you always ensure optimal alignment with the bronchial wall. So this is what I showed you, conventional or the Wang's needle. Nowadays, a lot of different companies are making various needles. There is the Periview Flex needle. This is one Boston Scientific, which I just took it from their website. As you can see over here, this makes it much more convenient also. This is a sheath and the needle inside, which is the metallic tip at the distal end. And this over here is the locking mechanism, which can actually put your sheath in and out. And you can see the suction using a syringe over here. Over here, it's approximately minus 10 centimeters water. So a lot of different kind of needles are available, because the TBNA procedure is now being done. So if you don't have an EBUS, you can go for one of these needles and make your life easier, although using this. Now, Another thing is cytology versus histology, what to do. Cytology is when you just get an aspirate, histology is when you actually get the tissue sample. So these are generally advanced through Teflon catheters, which may be approximately around 140 centimeter working length. Ideally, they are disposable, but yes, you can sometimes use it after sterilizing also. The cytology needles are usually 22, 21, and 20 gauges, and histology is typically 19 and 21 gauge. 19 gauge may not actually be required nowadays. There are a lot of meta-analysis and head-to-head trials which say even 21 gauge can actually, if your technique is right, you can get the right sample. So once your scope is inside, your needle is inside the scope, and you have seen, okay, my equipment is all ready. Next step is, of course, the nodal puncture. For that, you need to position your needle properly. How to do that? Say I select subcarinal station. I go ahead, I indent the subcarinal wall with my scope, which is also called bronchial wall denting, that is indenting it. Keep the bevel always facing upwards using your needle. Keep your hand steady for proper stability and insert at a 45 to 90-degree angle. Now, this depends on the node or the location which you are sampling. Now, most of the time when you're sampling the right paratracheal or the forer, it may be a 90-degree angle. When you're penetrating the subcanal node, it may either be straight ahead. It may be around 45 degrees, maybe around 60 degrees. So it really depends on that. Puncture techniques always make sure that you have good visualization. Why? You need to see the sheath out of your scope. You need to see the needle out of that sheath. Because if you don't do that, if you don't have vision, you may actually damage your scope by opening it inside only or retracting it with the needle on. Apply firm pressure, which is again the indentation or the tenting, and deploy the needle with controlled thrust. Once you do that, advance the needle into the target node about 1 to 2 centimeter. And this is something which is very important. Do not generally go very deep because you don't really know where exactly you are. You may be hitting one of the vessels out there, and confirm that there is no excessive mobility or slipping. I'll be showing a video subsequently. Now, what we spoke about was puncture. Now, the whole question is how do we puncture? There are multiple methods which are used, but two commonly used method are piggyback method and the jabbing method. Now, what are they? As you can see on the left side, the piggyback method. Once you put the needle out of and sheath and the needle out of your scope, what you do, you move your bronchoscope and the needle as a single unit and move it forward, which is typically your assistant is holding it and you just push the scope ahead and that itself pierces. This has an advantage that it gives that extra traction from the scope itself, because sometimes the mucosa may be hard and only jabbing may not be useful, that it may not really penetrate also. However, that is the jabbing method, which is the second method. That is, you keep your scope still and only the needle you push as far as possible. Now, sometimes, hard surfaces, cartilages, or hard mucosal surfaces may not allow for this jabbing method properly, and the needle may get bent. So, typically, you can select, okay, which method to use. Both may be worthwhile. Sometimes when patients are only given local anesthesia, they're awake. Dr. Atul Mehta has also described the cough method, that you put the needle over there and ask the patient to cough, immediately it penetrates. But yeah, I would generally recommend either a piggyback or a jabbing method for this. So another tip is how to reduce the scope damage. During insertion of this catheter and the needle, which is the sheath and the needle, the scope should be kept as straight as possible. This is important. The distal tip should be in neutral position. Again, because if it is bent or something, sometimes, okay, the needle, if just in case it's not inside, it may damage the scope sheath. The beveled edge should be kept within the metal hub of the catheter during its passage through the working channel, and use only retractable needles, because non-retractable ones again can damage the working channel. So once we have done this, we have punctured the node. How do we actually acquire a sample? Typically, two methods. It's either the suction technique or the capillary technique. Suction is when you attach, as we showed earlier, you apply the syringe over there with a negative pressure of about, you can apply 20 cc, 50 cc syringe, apply pressure of anywhere from -10 to -20. Generally, that is what is used. and perform 10 to 12 to and fro, 10 to 20 to and fro motions. Although it is said that, anywhere from 6 to 20, 6 to 10 is also okay, and there is no difference between that. Or without any suction, you just allow smooth passages and allow the material to flow up using capillary action. And this is typically there when you notice, okay, my node may be quite vascular. And this is something which may be evident to some degree on your CT scan, of course, because here you don't have the endobronchial ultrasound to use that Doppler. Number of passes, ideally you should do, or minimum you should do 3 to 4 passes per lymph node station. If you have ROSE, which is rapid on-site evaluation, and that is not satisfactory, you can go for more passes. Or maybe, if your ROSE says, okay, no, my sample is adequate, it is all fine, then you can stop early also. And always use new slides for each pass. So here's another thing, how many passes? Inside that, diagnostic yield increases incrementally until the seventh aspiration, but 3 passes are sufficient only when alternate sites, sampling sites are available. So if typically you have rows, clinical judgment is used to determine the number of needle passes. If you don't have it, 3 to 5 passes for diagnosis and maybe additional passes for ancillary studies, such as your molecular markers, IHC or something can be used. How to prevent bleeding? As we said, using a 20 to 50 cc syringe, we apply suction. If you aspirate blood, that indicates inadvertent penetration of a major intrathoracic vessel. Now, the whole thing is okay in certain locations, such as say your 4R, if you are hitting that ascending aorta, or if you are at 4L location where again the aorta is there, generally the bleeding is not much because these are at pulmonary pressures rather than at systemic pressures. So just be careful about it. However, if this occurs, the blood comes inside your syringe, you should release the suction, retract the needle, and select a new site for aspiration. Again, very, very important. Now you've done all this, you've taken the sample. Important part is how to process your specimen. This is again a very, very important part because ultimately this is why you're doing the procedure. So it's a very vital part. Usually dry smear technique wherein you express everything on a slide, rub the slide together, fix it and rapidly preserve it in alcohol to prevent drying artifacts. Or you can express everything in saline for microbiological studies, and usually cores you can either put in formalin for histopathological analysis, or again that can be put in saline for your microbiological analysis. Rows is important. In rows, generally, you have a station set up. Besides, again, I would recommend, if you're doing conventional TBNA, a very important value addition that you should have this, so that you can immediately see whether my slides or whether my samples are adequate or not. Should I process further or not? So the stained slides are generally screened by pathologists. Nowadays, a lot of pulmonologists are also doing it. Sampling and staining cycle is continued till adequate material is obtained. What do we say adequate TBNA sample? When you have lymphocytes in these smears, which generally suggests passage in the lymph node, and it is called diagnostic. So this is adequate if you have lymphocytes. Diagnostic is if your pathology is identified. However, when there are no lymphocytes, it's a non-representative sample, which means you have to sample again. So this is something which is important. Now here I've just put across, again, whatever I just spoke about, I have summarized in 9 or 10 points on what to do, and this is just a small video on how we actually do it. This you can see how the sheath and with the distal what do you call metal guard is there, and this is the needle out of it. Here we are sampling the subcarinal node. Once we do that, you just puncture the whole thing. Of course, what I spoke about the indentation and all, this wasn't done. We directly punctured it. This was with the jabbing method. Once the suction was applied, there is multiple agitations which were done. And once the agitations were done, about 8 to 10 out here, you just pull it back in. After closing, switching off the suction, you just pull back, you retract the needle inside the sheath, and you retract the whole thing inside the bronchoscope. And this is how you typically do a conventional TBNA. So with that one case, this was a 45-year-old female with history of mid-thoracic back pain, weight loss, anorexia, no fever, history of lymphoma in sibling, some significant, socio economic factors, and CT spine showed a small lesion at T6, which wasn't worth biopsying. On a chest CT, what was also noticed, you can see this necrotic lymph node around this hilar region or the 10R location, which was a little difficult at that point. This was point of time when, for some reason, EBUS wasn't working. There was some issue with the processor. So what we did is we went ahead and did a conventional TBNA with fluoroscopy and had a pathologist at that point of time just to see whether we do. And you can see the site that we selected. This is secondary carina. So we selected the site. Of course, what helped was fluoroscopy. You can see the fluoroscopy image. A faint image at the back you can see out here. And this is how the scope and the sheath and the needle is out of that particular sheath. So the fluoroscope is actually pretty, important value addition when you have these difficult locations, and really need to get those answers from there. And what it showed was, you can see over here, this was the granuloma. This was a necrotic granuloma. This is just the blood and your regular lymphocytes, which favored tuberculosis, and accordingly she was started on therapy for that. So to summarize, what are the tips to optimize yield, train well, internalize everything, and get supervision for those conventional TBNAs? Have well-trained assessments. Main thing is to have that careful CT assessment. Important is to know your landmarks always, always, always. Usually perform 25 to 50 cytology aspirates prior to doing histologies. When your initial phase of your, TBNAs or whatever, try larger lesions first. We also, selected some 4 centimeter subcanal lymph nodes. I remember my first subcanal lymph node for conventional TBNA. Subcanal location has the best heal, and it's very easy to identify, also usually free of vessels also generally. You can combine it with fluoroscopy for difficult location. Our experience and few publications also show that small cell carcinoma has the highest yield. Of course, in India, the thing may be different with tuberculosis and all. And always remember the 6 T's of conventional TBNA: computed tomography, type of needle, technique, what you're following for, puncturing, tissue preparation, and tissue interpretation with trained assistants. This can take you the long way. So with that, what I would like to say is that conventional TBNA, if done right, it's not exactly a blind procedure. Rather, you can have expanded horizons in this case. So this is what I would like to summarize and end my talk on conventional TBNAs. Of course, we will have a much, discussion on the finer aspects of this a little later. But I would like to move on to the second topic, which is again as exciting as the first one, which is endobronchial foreign body retrievals, step by step on how to do it. Again, important is pre-procedural planning. Important is to review the imaging, your X-rays and your CT scans, assess the locations, characterize the foreign body, get into history. What was it that precipitated the cough or that choking sensation? What kind of foreign body is it? Organic, inorganic? Assess the duration. How long has the cough been there? Because that can tell you, okay, whether, there may be bronchiectasis, whether the foreign body may have some granulation tissue around it or not. And accordingly, you need to plan your tools, because they do differ when you are dealing with either a say organic or an inorganic foreign body, and anticipate complications always and be ready for it, such as bleeding, migration of foreign bodies, and all of these things. Have your equipment ready. You can always decide between a rigid and a flexible bronchoscope. Have foreign body forceps ready, which may be alligator, rat tooth forceps, cup forceps, or even the pronged forceps, cryoprobes, baskets, suction accessories, fogging control and irrigation. This, what we have found useful is something called as the GI port, wherein we use regular irrigation as well as put the forceps at the same time. That allows for great vision, especially for those distal foreign bodies. So when to use, or rather when and why to use your rigid bronchoscope over a flexible. Now, if you're dealing with a large or a sharp foreign body, if you feel there is massive granulation tissue, there is severe airway obstruction, you need more enhanced suction, especially when you're dealing with some bleeding, you need better vision and better control of airways. So these are instances when you should go for rigid bronchoscope. And I'm telling you, it makes your life much easier, especially if you're just doing with a regular, what do you call, flexible bronchoscopy, it sometimes can, cause a lot of trouble because of majorly your suction channels and all. So rigid bronchoscopy is always preferable in such cases. So these are just basic steps whenever you're planning to retrieve. Identify your foreign body, choose the modality according to the foreign body, optimize the position of your scope with relation to your foreign body, dislodge it, extract it, and then reassess your airways. So, how to locate the foreign body? It's majorly the CT scan, especially if it is a distal foreign body. Once you're doing your bronchoscope, do a systematic survey of the airways. Assess everything properly, such as tissue edema. Is there any granulation tissue around it? How, whether my foreign body is impacted or not? Is there presence of pus? Is there bronchiectasis, because of, say, long-standing foreign body because of obstruction? Identify the orientation of the foreign body. Is it lying transverse to your airway? Is it longitudinal? Which part is the smooth surface up or what? But use suction minimally because this can cause displacement. Retrieval tools. Now, this is again a very important part. For your firm inorganic foreign bodies, forceps are generally used. If your foreign body is irregularly shaped, alligator forceps can be really useful. It has got multiple jaws, baskets for generally rounded objects, cryoprobes for friable organic foreign bodies, and there are other options such as hooks and balloons and magnetic forceps, which can be used, and there's a lot more than that. So most commonly used that we also use, and I think everyone else uses, is the forceps. What is to be kept in mind is align longitudinally with your foreign body. Ensure there is a firm grasp with your forceps before you pull it out, and generally you pull it out with as one unit with your flexible scope. Avoid tearing the friable foreign bodies because the remnants may be torn off and go distally also. And always maintain scope stability and move as one unit. So I've a couple of videos I would like to show here. You can see on this X-ray this opaque foreign body out here. We did a CT scan also, and you can see it over there very clearly in the coronal sections also. And once we went inside, you can see out here there is a needle out there. We used forceps and we were bringing it out. It was a little distal. As we are bringing it out, you can notice the orientation is slightly different, which can actually harm the airway. And we're trying to get it through our, sorry, we're trying to get it out through our rigid scope, but of course the orientation wasn't right, so we sort of turned it. And once we turned it, we could easily, sort of get it through our rigid barrel and take it out properly. This is how we repositioned it, and it made it much easier. Once we took it out, most of you can identify this was a hijab pin in a patient. And this is a second approach. This is a different kind of a forceps you can notice over here. So all these different forceps are available. This is a two-pronged forceps by Boston Scientific. Now the foreign body out here is a tooth. Now this was a patient who was intubated, and during intubation, apparently their tooth got broken, and this was deep inside. So we used this particular forceps because the surface was very smooth, so other kind of forceps were not able to grasp it. Yes, we've used baskets also for these, and you can see the grip is pretty good with this particular forceps also. So the idea is there are different kind of forceps which are available for different kind of foreign bodies, but this also does not work with certain very smooth surfaced foreign bodies. Because this was a little irregular but smooth, this really worked out well. Cryotherapy, a very useful tool in your armamentarium, especially for foreign bodies. And this is something that we use day in day out because the number of foreign bodies that we get is immense. Generally for organic friable foreign bodies, why? Because it can freeze the entire thing and prevent breaking of those particles also, and the residual foreign bodies. Generally a 2 to 5 second freeze, but I think it depends because sometimes the larger foreign bodies may require longer freeze time also. And again, this is also lifted as one unit with the scope. So here is an example. You can see on the CT scan, there is a foreign body around the right bronchus intermedius. which is there. You can see it's a well-rounded foreign body. What we did once we went ahead and did the bronchoscopy, you can see something is lodged in that right bronchus intermedius. We used a cryoprobe out here. We used about 5 seconds, 4 seconds of freeze time. We were taking it out, but again, we noticed it wasn't coming through the barrel. So we extubated the patient. We removed the entire thing en bloc. Once we went inside, those were the inspissated secretions which were coming out because there was complete obstruction. We collected lavage, gave antibiotics and all to this patient. And on the CT scan, you could have seen some bronchiectasis which had developed. Ultimately, it turned out to be a chickpea which was there. And similarly, we have so many different organic foreign bodies. Baskets, very, very important. This is something which you should have generally for rounded spherical foreign bodies. Now, there are different kinds of baskets which are available, different sizes which are available. There are Dormia's basket, there is zero tip retrieval baskets and all. The trick is to open it distal to the foreign body, encircle the foreign body properly, slowly close it around the object and gently withdraw it as close to your scope as possible so that the grip is pretty firm. Now over here I've just tried to demonstrate the technique of how to use a basket. Now this was a 51-year-old gentleman who had a foreign body, and he also knew that there would be a P which is there, so we decided to go for a zero tip basket. You can see it is lodged in the right bronchus intermedius. I will actually pause the video. Now this we could go as close to it as possible. Once we did that, we used a zero tip basket. I'll just show that. So you can see this is the basket which we opened. Now, the zero tip basket is something which is, a little smaller than your general Dormia's baskets and all, but has a more firm grip. Now, this we try to, how you could see. Now, either you can go and open it a little distally and then pull it ahead. Now, over here, what we did, I'll just play it again. We opened the basket, and through one side we just encircled it, and then slowly retrieved the basket inside so it forms a firm grip, and then retrieved it as close to the scope as possible, and you can see how it came out as one unit. So for these spherical rounded bodies, and you can see the whole thing is also pretty intact because the grip is quite nice with this. Fluoroscope becomes very important, especially when your foreign bodies are pretty distal, and that does not allow the passage of your scope. Now, yes, some may argue that you can go with the thin scope, your ultra thin scope, but they may not allow larger instruments which would be used to grasp the objects. In such case, using a fluoroscope, actually, you can align the scope with the foreign body, and a coordinated movement between the scope and forceps under vision may be useful. So this is something you can, sorry for the noise. Yeah, so you can see there is a small nose pin which is lodged deep. Now this was somewhere around the medial basal segment of the right lower lobe, as we could not really enter it, and you can see how the scope is quite proximal because ultra thin, we went inside, we had hard time visualizing it, and then the only radial forceps which was going through was not able to grasp it at all. So we used a 4 scope, and through that we passed the forceps ahead. You can see this is the alignment, and you can see how the jaws are opening up to catch the entire thing. As we caught the thing under fluoroscopy vision only, we started moving it upwards. It was a little upwards. Now the video is a little edited. We changed the orientation of the entire thing to have a better grip, and we could then take it out. You can see this was the nose pin screw that was there. The next important thing, so this is how your fluoroscope can be useful. The next important thing is, okay, you've taken it out, how to get it out of the glottis. Its main thing is to rotate to align the foreign body such a way that it does not cause damage. There are certain sharp objects, such as your needles, bent needles, and all, which can actually damage your vocal cords while taking it out. Or the large ones over here, what I've shown is this was a beetle nut, which is almost 3 centimeters. There was, this we took out almost about 5, 7 days back. Now, this was lost in the right main bronchus, and this was a horror to actually take it out through the vocal cord. Also, we used a rigid barrel, so we had to extubate. So, the thing is to minimize mucosal trauma and generally use your rigid for oversized object because they may need to be removed en bloc with the whole scope as I've showed over here. Post retrieval, always have an airway survey. Check for bleeding. Look for secondary fragments, and this is generally seen in friable foreign bodies such as vegetable matter. Assess for any mucosal injury. Certain foreign bodies you may need to come back later also because they may have some chemical reaction leading to granulation tissue. Confirm your airway patencies. And there are certain special situations such as foreign body in children, multiple foreign bodies, sharp objects, chronic ones with granulation, and radiolucent foreign bodies, which may require CT guidance. Always have that quality and safety checklist, tool readiness, backup rigid availability, stable ventilation. Keep communicating with your anesthetist, and always document everything with images. To conclude, success depends on meticulous planning and proper tool selection. Minimize the airway trauma. Always have a rigid backup, and post extraction assessment is very, very critical. So with that, I would like to end my talk, and I think we can go ahead. So this, I know I rushed through a lot of things, and we would like to know more in detail. I think discussion can possibly make up for it. So with that, I would just like to stop here, and I think over to Vishwesh.
Uh, Thanks, Amir, for a elaborative, concise paradox, but that's how the presentation was. So, with this, now we move on to the panel discussion for the day. So, we have a set of esteemed panelists coming across India to share their experiences. Mr. Nitin, can we have the slide, please? Yeah. First, we have our senior most but youngest by heart, Dr. Virotam Thomas, sir, who is always smiling and who is always energetic and experienced with lot of experience in interventional pulmonology and pioneer in EBUS in North India. And he has got also got excellence in healthcare award and inspiring pulmonologist for sure by the Economic Times of the year 2022, past president of numerous reputed organizations and faculties in various national and international conferences, and author of chapters in various books of pulmonary medicine. So he will be enlightening us with a lot of knowledge on these two topics. With that, we move on to our next panelist, my dear friend, all the way from Bombay, Dr. Vinod Chauhan, and always very accommodative of new thoughts and and an important member of the IAB as well. And he's a chest physician and bronchoscopist at Chauhan Chest Clinic and Kokilaband, Dirbani Ambani Hospital in Navi Mumbai. We move on to our third panelist, Dr. Jyoti Bajpai, and she has joined us all the way from Lucknow. And I keep seeing ma'am a lot of times in the LinkedIn, and she keeps sharing her experiences as well. And she's got amazing set of publications of 107 articles and 9 book chapters, including H Index journals in 11. And she has been associate professor at Department of Respiratory Medicine, KGMUC, Lucknow, a reputed and a prestigious organization. And she was a moderator at the CHEST 2025, recipient of numerous awards like William Osler Award, Women Physician Year Award, and including a lot of poster. And she has been an inspiring figure for the postgraduates in her institute and across the country. And finally, I think Samir, I need not introduce again. He will also be joining us in the panel discussion. And I think my
So,
slide has come up.
yes,
So
so behalf of the IIB, I'll welcome Dr. Vishweswaran, a well-known pulmonologist all over the country, not all over the country, but we can say the world. So he's attached with the Yashoda Hospital, Samajiguda, Hyderabad. He is the organizing chairperson, IP mentor, annual intervention pulmonology workshop, editor board member of Lung India Journal, executive member of guideline formulation on nebulization practice in India, winner of the best overall, best innovation, best video, world class, World Congress of Bronchology and Intervention Pulmonology, around more than 30 publications, invited at a multiple international faculty, have trained more than 50 national and international delegates. Most more of them have, I think, joined in this program. Featured as an Indian top pulmonologist by Economic Times and Outlook magazine. He is one of our asset in Indian Association of Bronchology. So I'll welcome Dr. Vishweswaran and hand over to further question and answer session and panel discussion.
Thank you, Dr. Vinod, for the introduction. So we move on to the first question to Dr. Virotham, sir. So what are the indications for conventional transbronchial needle aspiration in this era of EBUS?
Good evening, everybody, and very nice presentation by Dr. Samir. And thank you, IAB team, for this event. So the most common indication is, as we all know, is our mediastinal lymph nodes, basically, to rule out any malignant or benign diseases. For especially for malignant diseases, if we are having, like to confirm, and for staging also sometimes required for which stage, which type of malignancy we are having, lymphoma, metastasis, and staging also. And for benign lesions, especially more in the Indian context, tuberculosis is the most common lymph node that we are usually present, and sarcoidosis definitely. And third is lymphoma. And some tumors are sometimes pressing the bronchial wall or main bronchus or trachea. With that way, can with the help of CT scan, if that is having quite near, and there is no any vessel in between, that we can do that bulging site, we can puncture. Sometimes if patient is having large growth, and growth is sometimes very friable, and it's risky to puncture or take out biopsies, even we can take the TBNA from that lesions. And so these are other common, various not common pathologies, but most commonly we used to do for lymph nodes, masses, and like I think these are for the beginners.
Yeah, excellent point, sir. And one of the important thing which you touched, let's say you see a highly vascular tumor, don't jump to taking a biopsy. Maybe you can pass a needle and then aspirate and see whether it is highly vascular or not. So with this, we move on to the next question to Dr. Vinod. So now we see a expansion of EBUS services across the country. So do you feel still there is a role of a conventional TBNA? That is your first part of the question. And the second part of the question is, okay, let's say that I don't have an EBUS. I want to do a conventional TBNA. Are there still any contraindications to do a conventional TBNA?
Yes, thank you, Dr. Vishwesh. So, with the availability of EBUS since 16-17 year in our country, so first 4-5 years, it's a evaluation of the EBUS in our country. Now, with the availability, yes, one of the slide mentioned by Dr. Samir that while doing the procedure, some technical issues happen, and I think they converted into the conventional TBNA. So, if even though your EBUS system is available with you, because of some technical error, because of some needle issue, or the availability of some instrument, you may have to choose the conventional TBNA. For the new beginner who don't have the instrument at the peripheral part of the country, we don't have the instrument, then we have to learn to how to do the conventional TBNA. That's definitely helpful with the help of the CT imaging, all those things. So yes, during the COVID era, because some issues are there, so many people use the conventional TBNA. So even the era of the EBUS TBNA, yes, the conventional TBNA is its own place in the diagnosis, and we have to keep all this in the training institute always there, because even though you are knowing the EBUS, you have to learn the how to do the conventional EBUS TBNA, conventional TBNA. And yes, definitely, it's the resource limited setting, we have to do it. And yes, the sampling, the sensitivity and specificity is also good with the conventional TBNA, with the some carinal and subcarinal and parahiral node. And the contraindication to, if we are doing the conventional TBNA, the contraindication are, yes, the more or less same with the like EBUS TBNA, like the bleeding disorder are the main contraindication. And if the mass is like peripheral to the airway, it's not nearby the airway, then we have to avoid the conventional TBNA, and if you are not sure about the lesion and node, and the node lesser than the 1 centimeter, better to avoid. And easiest, as Dr. Samir mentioned, 7 and 4 are the good node. Better to avoid the peripheral and structure
Okay.
structure for the sampling.
Yeah, excellent points, Dr. Vinod. And for all the Gen Z and the Gen Alpha, millennials did do TBNA only with conventional TBNA. And back then also, they had a sensitivity of as high as 90% for picking up a tuberculosis or a sarcoidosis. So I think as the science develops and the instrumentation develops, we get more sophisticated. But there are limitations, as Dr. Vinod sir said. Let's say your instrument is not working, or let's say you don't have an access to an EBUS. It shouldn't deter you from doing a conventional TBNA if you see a pretty good nodes in the subcarinal region or in the paratracheal region. And but one thing where definitely the EBUS would score over these conventional TBNA is in staging, because in staging it would be quite hard for you to actually use your conventional TBNA. But only thing is, be experienced before you do it and try to limit it initially to your subcarinal node before venturing into the other stations. With this, we move on to the third question to Dr. Jyoti. So, what preparations are required before conventional TBNA? Are there any particular set of investigations you would like to order extra? And how do you prepare these patients? And what are the instruments that are needed?
So thank you, Dr. Vishweshwaran, asking this question to me. I think this is a very, very most important thing. It is nothing different from flexible bronchoscopy. As we prepare for any patient for the flexible bronchoscopy, we have to prepare for the TBNA. So, in the patient perspective as well as the instrument perspective, for the patient perspective, if the patient is hemodynamically stable, indication for the TBNA, we can take it in for the bronchoscopy as well as for the TBNA. And utmost and foremost, most commonly important thing is CT scan. If the patient is having a CT scan and showing a proper lymphadenopathy like mediastinal lymphadenopathy, subcarinal or hilar paratracheal lymphadenopathy 4 hours, so we can go for TBNA. And interpretation of the CTs are very, very important before doing any TBNA. And the second most important thing is the needles. If we have a 19 gauge, 21, 22, any gauge needle, gauge needle in our institute, I think this one is the best one because we're working in a medical institute. So I think TBNA not a obsolete. TBNA is a very, very important tool in current nowadays. If any institute have a EBUS, I think the yield of TBNA also increase after doing EBUS because we can analyze the things visually and real time in EBUS TBNA. But we get the clear cut ideas where the lymph nodes are 7 and where the lymph nodes are the 4 are. As we see in a CT scan, the lymph node in the right main bronchus at the 1 to 2 position, we can hit the 4R lymph nodes. And subcarinal, as already said by Dr. Samir, it's very easy to hit by TBNA needles. So I think preparation is not much different. We have to go as in the flexible bronchoscopy for patient preparation like blood counts, coagulopathy. It is not mandatory to do every patient PT-INR, but any patient who is a bleeding disorders or something else, anticoagulants, we have to look the proper history of the patient before doing any procedure or any bronchoscopy guided either by the TBNA, BAL or biopsy. But in the order, if we are doing a dealing with the like benign diseases, so we have to do TBNA first, then we have to go for the BAL, then endobronchial biopsy. So in this scenario, we have to look for all the parameters together as we prepare patient for the bronchoscopy.
Yeah, excellent points, Dr. Jyoti. I think the most important thing is nowadays is getting a needle of a TBNA, because the EBUS needle has become so rampant. Very hardly you find dealers actually selling a TBNA needle. So I think that we need to make sure that people have it. And with this, we move on to the fourth question to Dr. Virutam sir. So we heard about different ways of doing a conventional TBNA. So how do you choose your method, and in which scenario you choose any particular method over another?
Definitely with the practice, what I found is the piggyback method is a good method where you can do a sturdy jab and the whole assembly you can push forward, and it's very easy. But sometimes what happen when sometimes it's not puncturing, right? Especially the 4R lymph nodes, where the tracheal rings are quite prominent and the needle is not going properly. And even after changing few directions, then you can do the take out the needle out and gradually then jabbing method we can do. But the best way I have found is with good yield is the piggyback method. But definitely cuffing methods are sometimes we have tried. Even after putting this piggyback, we ask patient to cough out. So that is important when we have difficulty in jabbing or piercing the tracheal wall. Then all methods can be combined together. So it depends how you are how much practice you are having doing all these TBNA. But to start, I prefer for beginners, it should be the piggyback method is the safest and good.
Yeah, true, sir. And to Dr. Samir, so what is the diagnostic accuracy of conventional TBNA? And when you compare it to your EBUS TBNA, have you seen in selected cases the EBUS TBNA performs much better than a conventional TBNA? And I think we touched about it, like what are the stations that are amenable to sampling by the conventional TBNA?
Yeah. So I feel there is a lot of a lot of factors which determine the yield per se. Of course, when we compare it to EBUS TBNA, we do have a clear-cut advantage in EBUS that you are real-time seeing the node, you are confirming your needle inside. Nowadays, we talk about nodules also with CBCTs and all, you confirm that it is inside the lesion. Similarly, EBUS does that rather than being blind, you are there inside. So the main thing is the consistency is of diagnostic accuracy is pretty high. But when we talk about it, so there is this particular meta-analysis, I think, by one of the Chinese authors, which talks about when you have sarcoidosis, varies about 60 to 75%, for tuberculosis up to 70-75%. Lymphomas, of course, it's lower, 20 to 30%. Why? Because generally lymphoma, you need multiple area sampling, you need larger core biopsies and all, which may be a little difficult with your EBUS TBNA. But the meta-analysis overall suggests that there may be an 70% diagnostic accuracy with a conventional TBNA. Another limitation is for lung cancer staging because those hilar lymph nodes, especially the opposite side, it's very difficult to go in, and it's very challenging also because of the vasculature with conventional TBNAs. Other factors which determine it are experience. If you have done a lot of these things, the experience of this bronchoscopist matters. If you have larger lymph nodes, of course, your yield is more. If you have proper landmark recognition, the yield is better. And again, and one more emphasis is rows. Always have rows with it. If you can have rows, your yield improves by approximately 10 to 15%, if not more. Uh, with EBUS, yes, it definitely has superior diagnostic yield and is preferred technique if you have it, especially for lung cancer staging and for getting those scores for lymphomas. But if you have, as we discussed, resource limited settings and large, easily accessible nodes, conventional TBN is good enough. So this is typically how things are. But again, and the second part of your question, I would definitely suggest that 7, which is station 7, which is the subcarinal, and station 4 are. These are the ones which are close, easy to landmark, and relatively less vasculature, and that is what should be sampled with conventional TBNA, especially at the beginning of your career. If you're not very experienced, this will give you a lot of confidence, and then maybe venture into other stations.
Yeah. Excellent point, Samir. I think two things I feel would really change. One is the station position. Subcarinal, you are free to go. Most of the time, you get a diagnosis. Second, your experience, because many a times the needle actually doesn't cross the
Yeah.
bronchial wall. You're so afraid that you just pass the needle a little, and then you're like, okay, no bleed, I'm happy with it. You end up getting only a bronchial tissue. So I think a little bit of experience and choosing the proper node station actually makes the difference. So to Dr. Virotam sir again, so we know that in EBUS we use a lot of different needles, 21 Procore, then 19 gauge, and fans and tip needle, so many things. But when it comes to conventional TBNA, so do you have any such different sizes of conventional TBNA needle that are available? And the second part of the question is, let's say that once I am puncturing the node, how many passes do I really have to do per node station passes to increase the optimal yield?
So my preference remains always 21 gauge needle. Although the 19 gauge and 22 gauge needles are also available, but what Dr. Samir has already presented in his slide, that the study showed that 19 gauge, 21 gauge that sometimes require for the core biopsy, the yield is almost remain the same. So 21 gauge is safe needle, and sometimes we do with the 22 gauge needle also, but yield is almost similar. You use either needles, but 21 gauge is the better. Regarding the passes, 3 to 4 pass, at least one pass, 10 to 12 zabs should be there, and in one lymph node, 3 to 4 passes should be there for proper confirmation that is you have inside, you have done proper jabbing,
Yeah.
and you have done all these things.
Yeah, true. So at least for the beginners here, somewhere recommendation is at least 20 excursions and at least 15 to 20 excursions and at least 3 passes per node. But if you have a rows, then your number of passes depends upon what is the adequacy of your rows. And if you are very lucky, you get the diagnosis even with the first pass. So we move on to Dr. Vinod. What anatomical landmarks are crucial for guiding the needle insertions, and how do you ensure the safety? And let's say that I want to increase my yield, like having a suction, having the slow pull technique, or having no suction technique. So how do you actually choose to increase the yield of your samples?
So while doing the conventional TBNA, the anatomical landmark are quite important. The Karana is the main structure we have to visualize. So the best part is to do the sampling of the 7 and 4 lymph node, the subcarinal lymph node. If we are targeting the subcarinal 7 lymph node, we have to just go just below 3-4 millimeter below the carina and go lateral, go medially, and either of the side you have to go just below the carina. Don't puncture the exact middle sharp carina, and the 4 are also just come little bit 2 centimeter above, and you just pass the at 1 to 2 o'clock position. Better to avoid the 3 o'clock position. That is just the there is a pleura and or azygous vein is there, so you can puncture and you can create a complication. And in a 4L also you just laterally to the carina in the lateral wall. So the behind the lymph node, if the availability of the ebers better to avoid in a era where the available, because there are the if you are this is the, as Dr. Samir mentioned, is a blind conventional TBNA. So if you are not visualizing the node, if the nodes are small, just avoid the conventional TBNA and go only with the bigger lymph node like subcarinal and hilar lymph node. And in the sampling and the tissue, the method depends upon the person who train in which technique very well as per their yes, personal and own experience. And the suctioning, initially if you are suctioning, you just make a suction. If it is something is coming blood and all those things, just remove your needle. And if it is not coming, you can apply the suction, and suction gives the good sampling. And the gauge of the needle also is helpful. If you are using 21-22, the cytological sample are good enough. And if you are want to get a biopsy sample, core sample for the ISC and for the histopath, you can go ahead with the, if the nodes are bigger, go ahead with the 19 gauge needle. That will give the good core sample for histopath. And the sampling are depend upon the person who experience, who does how much how procedure he done in the past. So these are the
Excellent points, Dr. Vinod. But one or two more to what you have said. Let's say when you're doing a blind TBNA, especially for the beginners, it's always better to have a suction. Never try to do the slow pull or without suction, because you really don't know the anatomical landmark, and that is the only thing that can save you from a puncturing a vessel. And the second thing is, if you're passing a needle and if you feel resistance, that means probably you're hitting the cartilage. So never try to force through a cartilage, because you may end up uh, blunting your needle, or sometimes it can even start bleeding. So these are few things, as you keep doing, you'll understand much better. And to Dr. Jyoti, so is rose something that you do essentially in every case, or does your pathologist come to the suit, or you take a picture and send it to the pathologist and ask them to report it?
Okay, so we are mostly doing a telecytology, not a cytopathology is not available in our suits, because in a medical college they're very difficult to get it. But I think those who have rows in their centers, I think this is good. But it is not very essential to have every time rows in your center. First of thing, and because rows is rapid on-site evaluations, So in this category, we lot of meta-analysis has been done. They have shown there is a nothing better yield can be find out with these kind of rows, but only two things or three things we can improvise, like number of passes, as already said in the slides by Dr. Sameer. We can reduce the number of passes, and another thing, we can identify that material is adequate or not. So if we can't see the lymphocytes, so it means our material is not adequate. Sometimes it is help in triaging also for the like molecular analysis, or as well as for the PDL1 marker and other advanced techniques we can use it. So I think for a yield purpose, if don't those like institute doesn't have rows, is it okay? But we can use a telecytology also. Like in PGI Chandigarh, they have done a paper on WhatsApp. So they have retrospectively analyzed the data, and they found that these PROs, like a pulmonologist is doing a cytopathology nowadays. So we are also having a term like PROs. So they found that the yield was better in when the cytopathologist examined by the WhatsApp group. So, but it was done in a IBUS TBNA procedure. So I think cytopathology is also a very good tool, and it can be used. But those who have rows, it is also good, but it is not very mandatory to have everybody have a rows. Some pulmonologists can also take a good training in cytopathology, and they can start it.
Yeah, actually, that's what we have also observed, ma'am. Because the time we start doing ABS, most of the pathologists started revolting. So we finish a case late in the day, and they stopped coming, and so we started seeing the microscope. And off late, we realized like though we are not equal to pathologists, we are
Yeah,
still able
sometimes
to
we
make out a
analyze and we,
granuloma or an atypical cell to a certain extent. Another thing, what we started
yeah,
doing off late, yeah, please go ahead, ma'am. Yeah, you were saying something, ma'am.
yeah, sometimes we examine the like we pulmonologists examine the slides, and they commented on it, and they send the pictures to the pathologist, and they
Yeah,
confirm to each other, either like multidisciplinary kind of
yeah, true. That we were doing
discussion,
for quite some time, and now
get
what
a
we started doing,
consensus
yeah, yeah.
on it. I think this helped.
Yeah, I think we lost your connection, ma'am. And right now, what we are doing is something which the audience can actually look into it. Take a picture in your phone, put it into the chat GPT. Sometimes, not always, you can still get your diagnosis, but don't rely on it. It's not for everybody. You
But
still need
it
a
is wrong.
pathologist.
Chat GPT is always not true. I have
No,
also
not always true, but it at
I
least
have
gives
also
you that you are in the node.
yeah.
So maybe that's the thing.
No, I
Yeah,
think
So I
which
have
is
done it, but it is
yeah, one important part is that everyone should know how to identify lymphocytes. You
yeah,
know, if you do
yes.
that, you can just look the slides because that will tell you whether your specimens are adequate or not. And if
exactly.
that is there, okay, you can freely send across your slides, and there are high chances that you will get a diagnosis also.
Yeah,
So, because that is the most important thing to conventional TBNA, whether you have entered the right place or not. So
yeah,
that and identifying lymphocytes is not at all difficult. You know, whatever slides and all, you can see those purple ones.
yeah.
I think that is something which everyone should start doing.
True, very true, very true. And now we move on to the next question to Dr. Vinod. So, what are the best practices for handling and preparing conventional TBNA specimens for pathology? And with time of molecular studies and everything, do you think the sample that we get with a conventional TBNA is sufficient for PDL1 expression analysis in these lung cancer patients?
So that is a quite good question for me. Everyone during their trainings are interested in to learn the bronchoscopy, conventional biopsy, EVAS, TBN and everything. But my boss taught me to how to prepare the sample and how to take care of the sample from first day of my training. So preparing sample and taking care of the sample during the procedure is most important thing as per my boss who taught me. So the any sample we are doing, we have to prepare three things. First, we have to make sure that we have to make a slide for the cytology. Second thing, we have to go for the microbiology, and third thing, we have to go for the histopathology. So for the like a cytology, we have to just pour the needle and the air just push to make on the slide with the, and we have to keep the things in the formalin and we have to collect the sample in the normal saline. If the course come it, we can transfer that into formalin after it also, because if we go in the direct alcohol based solution, we can't take it for the molecular microbiological thing. If you are aspirating the pus directly, so you can make a once dry slide for the AB smear that will give the diagnosis on a fast track. And once you are getting if you are pouring everything on the normal saline, if you are seeing the any core in it, so you can transfer to the alcohol based solution for the histopathology. Yes, with the advance of the technology and techniques, yes, we can go for the conventional TBNA sample are good enough for the molecular testings.
Yeah, I think it depends upon the core which you get. Sometimes, even with a smaller needle, if the node representation is good, you may get a good core tissue to get to do all these ancillary studies. But sometimes you may see a very big node, but the representation of the metastatic atypical cells will be quite low. So I think more than the size of the node, it depends upon the characteristic of the node, whether it is purely a hard node. So that is where some of the times your elastography in the EBUS actually comes to play. So with this, we move to the next question to Dr. Samir. So you are the one who said that we have to identify the lymphocytes perfectly. So what are the common contaminants, artifacts, or the mimics that you would see in the patient while interpreting these TBNA specimens, and what information should be included in the final report to ensure clear communication?
Yeah, so I think you're asking pulmonologist a pathologist question, but still, what typically, sometimes reports we get is most commonly we get the contaminants when we talk about specifically is the blood or fibrin clots. So many a times, you end up getting a lot of good core material, and this I'm talking about in general TBNA, maybe conventional, maybe EBUS guided, and you seem like, okay, it's a very good core material, and in the end they say it was a fibrin clot. So that's one of the most common contaminants that we get. There are bronchial epithelial cells which are there, which sometimes they also say, okay, there, and that is where the role of stellate comes in. So again, this is something which I did not cover in my talk, but always, move your stellate initially, because that will dispel all your bronchial epithelial cells and reduce the contamination. Cartilage fragments are also seen sometimes, mucus plugs, and there may be other, sometimes say microorganisms or squamous cells, but microorganisms uh, could be part of your actual pathology also. Artifacts, many times, because the crush artifacts can be seen, but this is more common when you do those forceps biopsies and all, and typically these are visible as those smudged chromatin inside in those slides. Air drying can also cause artifacts, and this is typically if you do not fix the slides promptly. So typically what you have to do when you prepare the slides, immediately put that into that isopropyl alcohol solution. Otherwise, that air drying artifacts can be seen. There may be certain, say, degenerative changes or some other artificial particles also from your gloves. We have seen all of these are, pathologists usually calls and say, I can see this material, that material on it. And other than that, there are certain other mimics also, as you were talking about, whether it's a benign lymphoid hyperplasia versus a lymphoma. Now, of course, this all depends on your the pathologist skill also. And nowadays they do staining also immediately whenever they have some doubts. And similarly, granulomas, which may mimic tumor necrosis, or histiocytes, which may be there, and germinal centers, which may mimic metastasis. So multiple mimics are there. And finally, contamination versus an actual information. Now, what we have done is we have standardized our pathologist. We have told them, okay, report it to us, and they typically, before releasing the report, they ask us, they tell us few things. One, what is your clinical indication? What are the relevant imaging findings? And finally, they give the report, which is like whether, first thing is, specimen is adequate or not. That is there, whether what is the description of the various cellular components which are there inside, and finally what is the definitive diagnosis, and the fourth point is whether they recommend some ancillary testing or not. For example, they may tell us, okay, whether they see lymphocytes or only epithelial cells, blood. Second is what is the population of that lymphocytes, whether there are presence of granulomas, epithelial cells or not. Definitive diagnosis, what it points towards, and whether they recommend anything else such as AFB staining, PAS staining, or IHC markers or something like that. So this is typically how reports should look like in the end, and mostly have a good say basically a two-way communication with your pathologist in order to get a real-time feedback rather than having it all little later and maybe subjecting a patient to another.
Yeah, true. But I think for the dreaded contaminant, you will see is a gene expert trace detected. So
Yeah.
I feel that is the most dreaded one you will see. Now, moving on to Dr. Virotam, sir, what are the common potential complications of TBNA and how do you really prevent it? And which are the subset of population you think that you will be always looking for a complication except for a complicated patient? That complicated patient will always come with a complication.
So it is same like you are doing starts with bronchoscopy. Those all patients who are having like COPD patient with respiratory failure, having severe PAH, and having arrhythmias or such type of patients having quite obese patients like patients having difficult intubations. And so these are we have to look all these features in a patient, and especially the platelets, like if patients having less than 75, even more 50,000 less is having high risk of TBNA, and INR is more than 1.5. So these type of patients, you have to keep in mind that they sometimes having the common complications like bleeding is the most common complication. Most of the pulmonologists fear about the bleeding, and it's not very high number. But if you are puncturing, try to puncture 4L, where the high chance of the aortic this puncturing. So avoid this 4L, but in 4R and this subcutaneous lymph nodes, the minor bleed can occur. So bleeding is the most common complication sometimes, and pneumothorax is some. I've seen two patients of my patients doing this TBNA, and it can occur pneumo when you are puncturing, especially 4R, where there's a pleura coming the just near to this current trachea, and sometimes mediastinitis can happen. And one patient I have seen when I'm doing puncturing of this lymph node, that the caseous material popped out in the in the lower bronchus, and patient develops sometimes hypoxia. So other common complications like hypoxia, vasovagal reactions are not very frequent, but you have to keep in mind and you should know what complications can occur. And other complications, you have asked the one more thing important regarding which patients having larger complications when doing. Patients with having like tubercular fibrosis, the distortion of the medicinal architecture occur. Sometimes patients receive the radiation. Then again, there is a due to fibrosis and all these things, the common architecture distorted. So when you are piercing station 4 for you are thinking that you are going exactly at the 1 or 2 o'clock positions, it may be having sometimes vessels you are puncturing. So it's important to look. The CT scan is very important. How to go, which path you have to choose, and where you have to enter. So these are the, I think, all complications: bleeding, pneumothorax, mediastinitis, and hypoxia, vasovagal, and I think.
Yeah. So I think now we move on to the second part of the lecture today, which is the foreign body and something which excites everybody. So to Dr. Vinod, if suspecting a foreign body in lungs, what imaging modalities are used before going in for removal? Do you routinely order a CT scan, or for you an X-ray is sufficient before removal of the foreign body? I think you're on mute, sir. You're on mute.
So sorry, if any patient come to me for a suspected foreign body, yes, ideally I ask for the X-ray chest definitely. And if we don't have the facility of X-ray chest in that situation, and the patient is having acute problem, breathlessness, choking, and hemodynamic unstable because of the foreign body, we may sometimes go without the X-ray also. And after the X-ray, even if the patient is stable, yes, the facility is available. Then we have to go for the CT chest frequently to see the exact location of the foreign body and pattern of foreign body, because sometimes the children and young people, the foreign body usually comes for either in the children or in the old age. So sometimes they may not remember how what type of foreign body. So sometimes we have to see for that also. Yes, X-ray is a mandatory and CT chest to just locate the exact site of the foreign body and to avoid the complication. And the secondary thing, so CT scan will give us a hint of the any lung pathology, any lung condition that may land up in a complication during the bronchoscopy and during or after the bronchoscopy. So X-ray and CT scan are the good enough for that. With the help of the CT, we can create a virtual bronchoscopy with the help of the software also.
Yeah, I think, and an X-ray, even if a patient is carrying an old X-ray, always do an X-ray before entering. Sometimes the patient could have coughed out a foreign body or it could have moved to the other side. So that is very important. So to Dr. Jyoti, like, what should be the preparation while going for a bronchoscopic foreign body removal, and how important do you feel a trained assistant is?
So I think bronchoscopic removal of the foreign body is a very crucial step. Sometimes it may land up into airway emergencies. So we have to prepare for everything whenever we are removing the foreign body by bronchoscopy. And we have a multidisciplinary approach for this also. And we have a team whenever we are doing that kind of procedure. So as for we have to look for the patient history is sometimes we didn't get any aspiration history. A patient is having a choking, stridor, and wheezing. So look for these symptoms whenever you are going to the removal of the foreign body and give relief from that kind of symptom. Maybe some bronchodilation, oxygenation, pre-oxygenation, and always and look for the patient profile also. What kind of medication he was taking, what was his behavior, any neurological disorder, something. To take a proper history. And another thing is very important for your instrument. Whenever you are taking your patient in your OT or bronchoscopy suits, you look for all the gadgets which you have in your OTs, like flexible bronchoscope. Sometimes we have to required. We are doing a rigid bronchoscopy and we need a flexible, or sometimes we are doing a flexible bronchoscopy foreign body removal, and sometimes we need a rigid bronchoscope. So we don't know what kind of foreign body patient have taken initially by the CT and radiology, not all the time. So that thing, I think this is important. And third thing is very important, the team, anesthetics, and we have a proper trained assistant, because when we are doing a procedure, we need a frequent instrument exchange. So if your assistant doesn't know what instrument you are asking and he is giving some another, so it will delay or maybe leads to some complications also. So if you want a safe, successful procedure without complications, so I think your team should be very strong enough, and they are well versed with and they have a good knowledge of what instrument, what basket, what forceps you are asking during your procedure. So these things, and also look for the anesthetic. If you are doing a rigid bronchoscopy, foreign body removal, so I think you have to anesthetic by side your, or maybe any critical care expert, whichever you are dealing with that kind of things. So I think anesthetic person are the good one. And the trained assistant, I think you have asked, so I told you trained assistant is very very important when you are doing a foreign body removal in your patients.
Yeah, very true, ma'am. I think it's end of the day a team effort. And to Dr. Samir, like, whenever you are removing a foreign body, do you always choose a rigid, or foreign bodies can also be removed only with flexible bronchoscopy?
And I think it's a very, very important point. In fact, this we have also internally debated quite a bit. Okay, what sort of a conduit we should use? And I think to take into consideration, one is history, that one, what kind of a foreign body are we dealing with? Is it the size? If it's a large foreign body, whether it's a sharp edged foreign body, I would definitely prefer a rigid, because your flexible scopes and all, and just getting it through that conduit is very, very important. And otherwise, it can cause damage to your vocal cords, your mucosa, also these kind of things. Second consideration is how long has it been sitting over there? Is typically very long-standing foreign bodies are associated with granulation tissues, and just working around that granulation tissue can cause a lot of bleed, which can fog the vision of your flexible scopes alone. With this, you can at least have another suction catheter, which may be useful. Third is, if it is a long-standing thing, there may be bronchiectasis post-obstructive infection. So pus itself, what, or the purulent secretions may start flowing in, which can fog it. So these are various considerations that I would definitely take into account. Otherwise, and the location, of course. If it's something sitting in the main stem bronchi or in the trachea, which generally doesn't happen, or very say proximal segment of some airway, then yes, maybe you can just put in an LMA or under conscious sedation only with the flexible scope. You can just go and pull it out, especially if it's a simple one. But then there are other subset of foreign bodies. Say, for example, a chiku seed, or you may have a pin or something, and they are nightmare to deal with. All these smooth rounded surfaces which you really struggle with proper instruments and all. For these kind of things, I definitely prefer having a rigid scope. Further, if you need more suction, you have some airway obstruction and all, I would definitely recommend go for a rigid bronchoscope in these
Yeah.
patients.
And what are the instruments you use in the channel? I think you touched upon it in your lecture. But what are the common instruments that you use? You need to have, like if you're dealing with a foreign body.
So the common instruments that you need to have, one is of course you should be ready with various different kind of forceps. So typically what we use is different kinds, the alligator forceps, which are generally used for small, soft tissue, or but they are not useful for smooth rounded objects because of their multiple jaws may not really hold it. Many times we use this rat tooth forceps. Some irregular but smooth surfaces, we use this pronged forceps, the one which I showed for the tooth as well. There are all these triangular tooth or the shark tooth forceps, and then there are the cup biopsy forceps, which many times we pull out these seeds and all from inside. They are really useful for them. And hooked forceps for some, say, whistles. A couple of times we have taken out. They have been very useful. These are their baskets. I spoke about the Dormia, the tripod basket, or the zero tip ones. Even snares we have used sometimes when we did not have a basket which was working or not an adequate size. Uh, their cryo is one of the most important tools, is what I feel, for foreign body retrieval. It saves a lot of time, literally. You just hook onto it, but the only thing is it has to be an organic foreign body. But inorganic in the gamut of organic foreign bodies, chiku seed is one of the most difficult ones, wherein cryo nothing really works, and somehow you have to take it out. So these are things always important to have. Certain other tools, balloon is useful many a times for dislodging these foreign bodies also. And a lot of times we always pass across a suction catheter through a rigid scope also, because if there is a bloody field or something, or secretions which can continuously suck all these secretions, giving you a nice field with a lot of vision, that is always very useful.
Yeah, true. And Dr. Virotam sir, again, well, I think Samir has touched a little bit on it, but depending upon the size, shape, and the texture of the foreign body, how do you actually optimize your tools?
The most Dr. Samira already touched, but patients, those having the rough body, hard metallic bodies with rough surface, the rectal force is most, I think, appropriate to take out this. That can be strongly take out. And one important thing is like for smooth, like foreign bodies, uh, the basket is work very well, and sometimes the mesh, the like you have a mesh where the crushed artifacts can be taken out, crushed pieces can be taken out with this mesh. And even sometimes we used, I remember the first foreign body I removed almost 25-26 years back was the chiku seed, the first foreign body taken out. It was my first job at it. I remember it's very difficult and taken out within the piecemeal. We haven't at that time this cryo and all these things, and basket was not there, and it taken out with the rigid bronchoscope. So important is like smooth muscles, as cryo is the most appropriate thing. Even if patient is not having the organic foreign body, even you can still small saline over that, and sometimes it works, and you can take out this non-organic foreign bodies even by the cryo. So with so many tricks you can take out with different these forceps you should have always in your basket. And the rigid is, I think, is the best thing to conduit, to very frequently taken out this flexible bronchoscope, even if you are using flexible bronchoscope only.
Yeah, true. So, for the interest of the audience, if you have organic, cryo would be the ideal one. Inorganic, sharp, possibly a rat tooth forceps. Inorganic, rounded, or organic, rounded, possibly your Darmia basket. But at the end of the day, it's like a mixture of everything and not one instrument. And any doubt, if you have that you are capable of injuring the glottis or difficult airway, always keep your rigid at the back of your mind. And to Dr. Vinod, this is a most important question. If at all one take-home message has to be there from this is this one. Let's say I'm removing a foreign body. I'm stuck at glottis. A nightmare for you, the anesthetist, and everybody. So what are you going to do?
So, while taking care of the removing the foreign body from the glottis is the most important thing is to just to prevent the injury to your vocal cord and the surrounding structure. So, if any foreign body like Dr. Samir showed the one video that tip he hold inside the forceps, the injurious part that he holded the blunt part and he removed with this. Initially, with the like a flexible bronchoscope, you have to convert those things. If you are not able to remove the foreign bodies from the glottis or vocal cord, you have to convert this procedure in the either in the rigid bronchoscopy. If you are not well enough trained in a rigid bronchoscopy and rigid bronchoscopy is not available in your endoscopy room, you go for the bigger endotracheal tube and you have to remove with that help. If the foreign body is bigger and organic, you may uh, do the some breakage of it with the help of your instrument and you can bring it out. So if the foreign body is easily slipping from your scope, you hold it and you remove the assembly altogether from the glottis vocal cord. So the
Yeah,
most
true.
important to avoid the injury. Anything you can add also, sir.
So I think this is something which everybody should know. It's like whenever you're removing a foreign body, if you feel like it is going to be a sharp end or it is going to create some sort of edema or you need to pass your bronchoscope repeatedly multiple times, always keep your rigid at the back so that whatever you do, even if the sharp end comes, it comes inside the rigid barrel and it will not obstruct your glottis. The second thing is while removing, especially for the chiku seeds and the seed thing, when it gets stuck into the glottis, the first thing you do is don't try to pull through the glottis. Just push the foreign body down, take it to the right or the left lower lobe bronchus so that you can at least ventilate the patient. If you try to maneuver it more near the level of the glottis, it can cause a glottic edema. And especially in children, the glottis will be the narrowest portion. So you will not be able to ventilate it. And after that, whatever you do will be very detrimental. And the third thing which people who are starting new should really know is always keep an ENT on the backup, especially when you're dealing with the kid. So you need not go for extensive ECMO or something. All simple thing what you can do is like if you find that you are going to have a complicated foreign body, tracheostomize the patient, or you are not able to remove it at the level of the glottis, push it down, tracheostomize the patient. Later you can easily remove it with through the tracheostomy or under some proper guidance. I think if we follow these things and or if a patient comes to you already with a glottic edema, don't rush to remove the foreign body. Tracheostomize, then you have all the time to remove these foreign bodies. So I think especially in kids, even when we do, we always keep the ENT on the standby because if I am not able to do the first thing is not removal of the foreign body, is the stabilization of the patient. I think this is something that people should know and don't rush to the real problem that comes in foreign body removal is you go unprepared. So you may be very good at localizing the foreign body and removing, but if you don't communicate to your anesthetist, then if he has not kept the deep plane of sedation while removing at the level of the glottis, the patient will cough and you lose the foreign body. Or if you have not trained your assistant properly, he will not hold it tightly. So while removing, you may still end up losing the foreign body. So I think proper preparation is of utmost key. So now we move on to the next question to Dr. Jyoti. So what techniques are used for removing different types of foreign bodies, such as sharp objects versus soft food particles?
So I think this is already covered by Dr. Sameer. When we are using a sharp objects, so we have to use the most probably rigid in our center we are using for removing the sharp objects. And whenever we have to remove it, the sharp object, we have to be very careful. Sometimes they will erode the mucosa and a lot of bleeding can occur. Sometimes we can't able to retrieve these foreign body by doing this. So one thing I think very important to rotate the end of this as shown by the Dr. Sameer is also in his video when he showed how to remove the sharp objects by rigid and we can use the like rat tooth basket, rat tooth forceps, and these forceps can be used for removing sharp metallic objects. So I would not suggest for removing these sharp objects you have to use a flexible bronchoscope. So for whenever you are dealing with the sharp objects, you have to use a rigid bronchoscope, and we can try to turn the sharp edges towards the downwards, and then we have to remove. And one is thing is very important: whenever we are removing any foreign body, we have to remove the whole end block circuit together, not the only. We will not try to, for the trainees who are doing it, so they are trying to pull out the foreign body immediately by the forceps. So don't do this mistake. Always yeah, whole the channel should be removed thoroughly and immediately. And after removing this like foreign body, always go for the repeat check bronchoscopy to check if there is any remnant or any bleeding or any trauma happened. Might be patient develop the edema also. So that point should be keep in mind whenever you are removing your sharp objects kind of things.
Yeah. And to Dr. Samir, what are the essential steps to perform the foreign body once it is removed? Let's say you remove the foreign body, you are done with it, or what are you going to look into it further?
I think as I mentioned earlier, also it's important that once you remove it, you have a proper airway survey. The reason for that is one, you have to check for any bleeding, especially if there was you had to do a lot of maneuvering. If there was some, granulation tissue around it, you had to dislodge with a great deal of difficulty. Second, very important part when you are dealing with all the organic friable foreign bodies such as vegetable matter, and this we have seen in cases of peanuts. We've seen fragments inside. We have seen bits of cauliflower with some fragments left inside, and similarly multiple other things. So you always check for secondary fragments, maybe distal to where your original foreign body was located. So here in your the smaller, the thinner scopes may be very useful. Third thing is all the edema around it, with all the maneuver, with whatever maneuvers you have done, there would be some tissue edema which is around it. So you have to go and assess it, and, accordingly you can deal with it also later with some medications and all. Pus, purulent secretions, which may be overflowing once you relieve the obstruction. That is something wherein you can just suction everything, collect it for your microbiology samples, also and appropriate antibiotics. That is important. And above all, just to confirm your airway patency, we have also seen that, as I mentioned earlier, that certain foreign bodies such as betel nuts, they release certain chemicals such as ercolin, which actually cause some surrounding tissue reaction, which leads to a lot of granulation, which leads to narrowing. And in fact, we had to do some balloon dilatation at this point, at after before removal and after removal also, to just free a lot of secretions from inside to clear off that infection. So these are certain things which become important for a proper airway survey even after you remove your foreign body. So that's a very important step. Without that, your foreign body retrieval process is, in my opinion, incomplete.
Yeah. Now to Dr. Virutam sir. So what is the best approach for a patient who presents with a chronic foreign body? So do you directly go for a foreign body retrieval or any pre-procedural stuff you wanted to try?
Very important thing is that if you are suspecting this chronic, we have checked with flexible bronchoscope that there is a occlusion is there, granulation tissue is there. So leave it there and start with steroid for 1 or 2 days for good antibiotics, because sometimes what happen, and get the CT scan, check the distal airway if there is a bronchiectasis is there. So high chance when you remove this type of foreign bodies, there is a pooling of the secretions of the pus will come out and spread out. So with you leave this patient for 1 day or 2 days and prepare for the steroid antibiotics, and then start doing this next after a few days, start taking out with the whole assembly. Like start with the most important is rigid scope. Start with rigid scope, and if there is granulation tissue is there, start by piecemeal. You can take out with cup biopsies to remove this granulation tissue. If bleeding is there, you can use APC, even electrocautery, or even cryo. So just make out. And sometimes what happens, there is the proximal the constriction occurs, stenosis occurs within the chronic few patients, you can dilate with the balloon. So make a passage clear, then you gradually take it out. You should take out this the foreign bodies. It usually granulation tissue most commonly occur in the organic things like yeah, Dr. Samir says some in the betel nut, and in the metallic foreign bodies sometimes they just embedded in the mucosa. So it's sometimes very difficult to take out. If there is a large bleeding, if it's not controllable, yeah, ask your thoracic surgeon friend to stand by, because it sometimes do large bleeding. So important thing is prepare patient and remove this granulation tissue, and then you can take out properly and do the proper lavage of the distal airway to clean the this all necrotic area. I think these steps will work, and you can do chronic foreign body removal easily.
Yeah, excellent point, sir. To Dr. Vinod, how do you manage a foreign body that is lodged in a difficult to reach location?
So any foreign body would lodge in a difficult to airway, so difficult to remove. The there is some we have to follow some step by step. So we have to go for the CT scan. We have to discuss with the radiologist the exact airway, where the location, and we have to go for the virtual bronchoscopy. Then we have to go with the bronchoscopy. If the rigid bronchoscopy is available, yeah, definitely go for the rigid bronchoscopy, because you have to go multiple time in and out. If not available, go at least for the LMA. Inspect your airway properly with your normal scope. Find the exact location of your foreign body with the help of the thinner scope, and with the help of the thinner scope and your regular scope, the as I mentioned, Dr. Samir shown the fluoroscopic image guided foreign body can be removed with can be removed. The here the role of the cryo probe is also valuable. If you locate the exact uh, site of the foreign body, with the help of the fluoroscopy or cryo probe, we can able to remove it. And definitely I go with the, because multiple time in and out, so the ideal choice is the with the rigid bronchoscope.
Yeah, very true. And to the last question to Dr. Jyoti, before we take the audience questions. So, what are the proper best precautions you take post procedure, and how do you prevent a complication like an airway stenosis from happening?
Yeah, so after a procedure, at least as we do in our routine procedure in bronchoscopy, every patient should be monitored for at least 1 to 2 hours or 2 to 4 hours. So initially 1 to 2 hours very important. Immediate workup should be done immediately. You have to, after removing the foreign body, you have to check for the vitals of the patient. Sedation has been removed, so patient sedation has been given. So you have to check for the consciousness, gag reflex, as well as for the stridor after removing, and these things, and oxygen saturation, heart rate, blood pressure. So these vitals should be checked whenever after removing the immediately, as well as 1 to 2 hour of 4 to 6 hours. So after 4 to 6 hours, if the patient is having a fully stable saturation, is maintaining, no stridor, no wheezing, and like everything is okay, then you can send to patient to home. But at least these 6 hours are very important for these clinical signs and symptoms you have to observe. Sometimes patient may land up in bleeding, sometimes they develop edema also, stridor also. So as per these we have discussed already, these things should be managed. Like sometimes we have to give steroid also for that patient, and nebulized adrenaline also that patient should be given post procedure. And after the discharge, 4 to 6 hours at least, these patients should be followed after 1 to 2 week as well. As and one thing is very important, x-ray, though it is not very much recommended, but we do in practice whenever we have like 3 or 4 things, so we have to do x-ray at least needed. Like if a metallic granulation has been removed, lot of granulation has been seen, and during procedure went for a longer duration of the time, and as well as when the bleeding has been seen, so that point should be considered, and x-ray should be done after post procedure should be done. I think these things are very important to prevent the complication, as well as also complications should be prevented by the team effort, good team, as well as a good procedure which you have done, how the operator is skilled, and how his team or his her team is assistant to his skills. So that's why we can complication can be prevented, as well as if the patient having a large bleeding, as sir told, CTVS has been with if you told like if a glottic obstruction is there, so ENT person should be there. Might be patient land up needs a tracheostomy, but these are the cases are very rare. But these things should be keep in our mind. We can call our friends in ENT as well as in surgery if the lot of great complication. But with the good team referred, proper selection of the patient, proper imaging techniques, and proper forceps, and which instrument you have used technically good. So I think we can prevent the complication and proper monitoring of the patients. I think that's thing are
So I
required.
think we'll quickly take the audience questions. So to Dr. Samir, how does TBNA differ from endobronchial biopsy? Dr. Naveen from Mumbai. Basically, he wanted to ask like when you have an intramural growth, so how does your TBNA actually help?
So biopsy is actually just taking a piece off of it, and while TBNA is that you put a needle inside the whole thing. So a couple of things. One is if you see a particularly vascular tumor, when you take a biopsy, it can bleed quite a bit. In these cases, you can just put in a needle and take some aspirates that can really give you the answers. And second thing is many a times we do see okay there is an endobronchial growth. A person somebody a patient has been referred wherein they did a biopsy and it showed some granulation tissue because long standing there will be secretions inspissated, and when you take the surface only that shows granulation tissue, in which case either take deeper biopsies or just put in a needle and then take an aspirate. So these are few instances wherein your TBNA can actually help in those endobronchial masses as compared to your TBNA biopsies.
And one another area where we found a little bit of benefit is, let's say you have a tumor-like thing, you take a biopsy, it comes as fungus, you don't believe it's fungus. Sometimes you pass a needle below and take it, actually the tumor is covered by a fungus. You end up taking the fungus and started treating as fungal infection. Second thing is to Dr. Virotam sir, how does the diagnostic yield of conventional TBNA compare with EBUS TBNA in sarcoidosis? I think you will be the right person, sir.
So station 7, subcurrent lymph nodes, the study shows these are almost similar. If having good experience, and for sarcoidosis and tuberculosis and all these things having almost similar result. However, overall results, if you combine with the EBUS, is superior with conventional TBNA.
Yeah. And to Dr. Vinod, how does the diagnostic yield of conventional TBNA compare with EBUS TBNA for suspected lymphoma? You're on mute, Dr. Vinod.
So the result of the conventional and EBUS TBNA are more or less equal with the lymphoma also, but yes, better with the EBUS TBNA because we are getting more sample and we are more passes with the different station also.
Yeah, I think with the help of intranodal cryo, now we are getting a better yield with lymphoma. And to Dr. Jyoti, explain why TBNA can sometimes upstage but cannot reliably downstage non-small cell carcinoma. Dr. Praveen from Indore.
So TBNA is, as already told, that TBNA good yield and greater accessibility for the level 7 as well as 4 hours. So as we higher the low nodes, we can identify if we can identify the subcarinal lymphadeno, subcarinal lymph node positive, so we can higher the stage of the lung cancer. So I think that's why the TBNA, because the yield is very good and most accessibility in the 7 and 4 hour. We can't go for a 11 hour or 11 by the TBNA, conventional TBNA. So that way, if you are in able also, if you are getting a higher load like a supraclavicular, it is a, for a anybody who having a supraclavicular lymphadenopathy or axillary lymphadenopathy, you get a less invasive tool are always better to diagnose a lung cancer or for the staging. So they get higher staging for the lung cancer. So in that scenario, you avoid these very invasive procedure for further workup. So I think TBNA is a good tool for the if you get a 7 lymph nodes positive for the malignant cytology or for lung cancer staging. So I think it is a that's why it's a good one.
Dr. Samir, what is the minimum number of passes per mediastinal lymph node staging, like station?
Yeah, so typically it's 3 to 5. So generally we restrict to about 3 to 4 passes. We see how much, what is the kind of material that we get and how many slides can we get out of each thing. But generally recommend 3 to 5 passes. You can go up to 7 passes also, but yeah, usually 3 to 4 minimum, I would consider that.
And Dr. Viratham sir, what infection prevention steps should be taken before TBNA by Karandeep from Chandigarh?
Same like in bronchoscopy. Important thing, every time use the fresh needle because it's like quite cheaper. Indian needles are also there and should make proper sterility of the procedure. Don't touch this needle tip when you are preparing the slide on the glass, because it's the most commonly happen when you spraying and then you touch the needle over the slides. So avoid all these things. I think these are the simple precautions you can avoid. If you are suspecting any necrotic lymph nodes on CT scan, you can give antibiotics, because sometimes, as already told you, one of my patients get this, the pus, the aspirated patients go inside the lower segments.
And Dr. Vinod, how would you differentiate an adequate TBNA sample from a diagnostic TBNA by Dr. Satish from Bangalore?
Adequate EBUS TBNA sample
From a
from
diagnostic. Diagnostic. What is the difference between the terms adequate and diagnostic?
So the adequate sample is, as I mentioned, mentioned by some earlier people. So 3 to 5 passes are enough. The good, even the 4 5 slide, if you make with a good chunk of the aspirate, is good enough to give a diagnosis. And if we get even the small core and in a proper core, small core is also valuable and it can give the diagnosis. But if small core may not help in a IS further molecular testing, but even the small sample aspirate, if you make a good rather than making a lots of 10 15 slide, if you make a 2 3 4 5 slide, even my pathologist asked me, if you make a 2 3 slides are also enough, and the sample aspirate sample of at least 3 to 3 ml is enough for the molecular microbiological diagnosis also.
Yeah, and I'll take the next question. What are the long-term complications after delayed removal? How should you manage foreign body in right main bronchus? So we had one patient who had a 16-year-old pen cap accumulate, like he aspirated a pen cap 16 years back, and with recurrent pneumonia later they diagnosed, and they tried to remove the foreign body. They couldn't remove. That's when they sent to us, and that was a nightmare because it took 3 hours in the OT table. And what we had to do is we did something innovatively. So through we tried with all, like nothing came out. So in the end, we had to pass a gastro forceps through our working channel so that we get a better grasp of it. At the same time, we passed a Fogarty balloon distally to give further traction. And then we have to do the corkscrew motion, and then we have to remove it. And sometimes when you deal with these complicated long-term foreign bodies, you can have a lot of granulation tissue. So your job doesn't end only with removal, because these patients will go in for cicatrization. And sometimes you can still have a stenosis and lose the distal portion of the lung. So you need to do a check bronchoscopy at the end of 2 weeks. And then if required, you need to do a balloon bronchoplasty to open up these airways and keep it patent. So, and right main bronchus, Dr. Vinod sir, yeah.
Sir, as I rightly mentioned, at around 10 years back, we did one interesting foreign body removal. The boy presented to us with a chronic cough, not resolving pneumonia and cough. So someone removed his LL. Have small the things. So there are the old vessel like this. So
Yeah.
they removed the petal from the vessel, and the circular part is lodged inside the
That is the
throat
most
only.
difficult to remove.
Yeah,
True, sir.
and after 6 months we removed it, even though we not finding, but somehow we are a team, so someone noticed there is something. We removed some granulation tissue, and then we removed that the circular part of the vessel after 6 months of initial removal.
True. And Samir, why is TBNA particularly useful in patients who are radiologically N0, N1 but have central tumors?
This is not only true in central, but all the tumors. In fact, we've seen that EBUS TBNA or in general TBNA has a higher sensitivity for upstaging a cancer. And I think this is maybe in continuation to the previous question also. Because many times we see, okay, even if a PET is negative, there is no FDG uptake. We tend to do staging for all the lymph nodes beginning from the opposite side, which is the N3 nodes. We do it, we label it properly, and we see that, okay, if any of those is positive, it really upstages the whole, what do you call, the cancer staging. And then it can make a lot of decisions that, okay, whether you go for a proper curative intent or a palliative intent, or how to go about it, whether surgery or you go for say some kind of chemoimmunotherapy. So I feel that's very, very important, irrespective of what you have tumor. Yes, central tumor, definitely T2 is there depending upon the size, but still it can be stage 1B to 2A, 2B. But if you have any of those nodes positive, it can really go into that stage 3A, 3B if your nodes are positive. And therefore, TBNA becomes an important modality.
Yeah, and to all the panelists, now we are going to have a rapid fire, quick answers because we have an extensive set of questions. To Dr. Jyoti, ma'am, what was just quick answers, ma'am? What post-procedure monitoring is required after TBNA?
Yes, it is required because we are dealing with the agarus vein in the when we are dealing with any procedure, it is an invasive procedure, so monitoring should be done. And oxygenation, as I told you, vital monitoring and risk for the bleeding you have to assess.
Yeah, so bleeding and infection, most important
Am I
thing. Next to
audible?
Dr. Yeah, you're audible, ma'am.
Yeah, yes.
Next to Dr. Virotham, sir, Shubham from Mumbai. Which mediastinal lymph node stations are suitable for conventional TBNA?
4R,
EBS TBNA? Yeah, I think just quick answers, sir.
4R and 7.
4R and 7. To Dr. Vinod, what are the typical diagnostic yields of conventional TBNA?
Sarcoid and tuberculosis.
Okay, so I think the diagnostic is somewhere around 70 to 80%. Yeah.
Yes.
And to Dr. Samir, Dr. Jyoti from Delhi, what are the common reasons for false negative TBNA?
So all depends on the sensitivity. Anyways, it has low sensitivity, low vision, and operator inexperience, and maybe incorrect technique, hitting the vessel maybe in the wrong location. So all of these are reasons for a false negative TBNA, and contaminants.
Yes. And to Dr. Jyoti again, Dr. Satish from Bangalore. No, that's not a comment. Okay, so Dr. Sudhir from Jaipur, how does TBNA support the staging of lung cancer? Quick question, ma'am.
So yeah, it support the staging of lung cancer. As I told you, 4R you get easily assessed by the EBUS TBNA. If you get the N2 subcarinal lymphadenopathy, you get, and you are getting a positive, it means N2. So whenever you N low know this N2 is positive, so also you can define the ages American IASLC staging for the lung cancer.
True.
It's
So
useful.
the important thing is station 7. If it comes positive, it becomes N2, possibly a surgically non-resectable case. And to Dr. Virotham, sir, Dr. Joy from Kochi, discuss the role and limitations of ROSE during TBNA.
The limitation of ROSE, definitely every hospital is not having the ROSE opportunity, but as you already mentioned, you can take a picture and send to the pathologist, or you can put on all these gadgets you can use. But the limitation is that you requires detail in one smear. You can't sometimes find, like lymphoma requires multiple slides. So definitely limitations are always there.
Yeah, and to Dr. Samir, Dr. Suraj from Nagpur, why is TBNA particularly challenging in suspected lymphoma? What histological or technical reasons explain this?
Yeah, so one of the things is because you need, because lymphoma, again, not all the, not the entire lymph node may be affected by it, and therefore you typically need various areas to be sampled. And second thing is you need larger samples and that's why you've seen, okay, cryobiopsy or maybe a forceps biopsy gives a much higher yield than just your conventional, your transbronchial needle aspirations.
Because in cytology, you'll just see a monomorphic lymphocytes.
Exactly.
So actually, you need a
proper
tissue
diagnosis.
sample. And quick answer from Dr. Vinod sir, Dr. Muthukumaran from Chennai. How does ROSE improve diagnostic accuracy?
Yes, ROSE definitely improved the diagnosis accuracy on site and with the confirmatory diagnosis. Yes, ROSE definitely plays a role to give the.
True. And I will take this question. So outline your approach on TBNA in patients on aspirin alone. TBNA is quite safe. You can do it with aspirin as well. Dual antiplatelets, again, TBNA is quite safe. There are enough evidence to say you can use it. But if you are a novice, try to stop the clopidogrel for 3 to 5 days and continue the aspirin, and you can take the TBNA. But if you're doing intranodal cryo, then definitely better to stop your clopidogrel. And apixaban, we generally stop at least 48 hours prior to doing it. The question was from Dr. Uday from Mumbai. And to Dr. Jyoti, Dr. Chandrasekhar from Hyderabad, when should sedation or anesthesia be considered during TBNA?
So TBNA, conventional TBNA is a very safe procedure. It should be done very like topical anesthesia. But whenever the patient is very agitated or patient is not very cooperative, and you want to do, you don't have a bus TBNA, you want to do a conventional TBNA for diagnosis. So that time you can use sedation or like general anesthesia for doing a TBNA.
Yeah.
But ideally, the patient is stable, you can go for
Yeah.
local anesthesia for the TBNA.
To Dr. Virotam sir, Dr. Kamal Kant from Varanasi, risk of pneumomediastinum during TBNA, your experience?
Very low. I have not experienced any pneumothorax.
Yeah,
Question.
it's quite unlikely until you wanted to puncture the airway, for sure. And to Dr. Samir, Dr. Ranveer from Udaipur, what are the most common types of airway foreign bodies in your practice?
The most common we see are two. In men, it's betel nut. In women, it's the nose pin. These are most common that we see. Apart from that, we see clove. We see peanuts also. And then in kids, of course, there is coins we have seen and toy particles.
So, and to Dr. Vinod sir again, what is the approach for suspected organic foreign body with surrounding granulation tissue? And what factors determine whether TBNA or foreign body should be performed under rigid or flexible? I think we tested it from Dr. Vikash from Ranchi. Can you just brief a little, sir?
So if any organic foreign body, if there is, we have to just clear the granulation tissue, and we have to remove as much as the particle around it, and we have to check for the further down, is there any particle size, particles of the granulation tissue, and we have to give the good antibiotic coverage before and
Yeah.
after this. And the second part of the question is,
Rigid or flexible for foreign body removal?
best approach is rigid. If not available, we have to
Yeah,
go with
sure,
the
sure. And Dr. Jyoti ma'am, which patient symptoms suggest airway foreign body aspiration? Dr. Kiran from Noida. Any symptoms which would make you suspect that the kid has aspirated a foreign body?
So choking, stridor, these are the most common symptoms. Sometimes persistent cough also, but for in the kids, I think the stridor, wheezing, and non-responding cough.
Yeah,
So these things are the very suggestive of acute
true,
foreign body aspiration.
true. And from Dr. Raman from Ludhiana to Dr. Virotam sir, what is early detection? Why is early detection crucial in foreign body aspiration?
Why early? The same. If you avoid, you have lots of complications, pneumonia, recurrent pneumonias, hemoptysis. Even sometimes I have presented two patients with severe hemoptysis
Yeah.
and granulation.
So I'll take the next question, Dr. Mohan from Bhubaneswar. How should an airway perforation be managed if it occurs? First, you don't create it because it's going to be a nightmare. Second thing, in case if you create it, if it is a very small perforation, generally it heals. Try to avoid any positive pressure ventilation in these patients. And the third thing is, if you have created a big tear, just put a silicone stent for time being and then allow it to granulate. But if you feel it is not working, call your thoracic surgeon. So what steps to reduce the risk of pushing the foreign body deeper? So whenever we do a foreign body, we always put the patient in reverse Trendelenburg position so that even if it, while attempting, it goes below. I never try to push a saline directly because it may dislodge your foreign body distally. And if it is hanging sort of foreign body, try to pass a Fogarty distal to it and inflate it so that even if it comes proximal to the Fogarty balloon. When should a foreign body retrieval be aborted? The moment you feel that you are pushing the foreign body deeper, or if you feel like it's a very sharp end foreign body which is capable of causing a perforation, then abort it, and bronchotomy can be done and the foreign body can be safely removed. If, sir, if a CT guided biopsy is possible, then should it be preferred over a TBNA? There are certain centers which use the paraspinal approach, especially the interventional radiologist, to go and target the lymph nodes. But I think that should be done in an extremely cautious setting. I feel with EBUS available, most of these nodes can be easily accessed without creating much of a complication. But let's say your interventional radiologist is extremely good enough, like in few places, they just go take the CT, they take the paravertebral axis and then go and hit even the subcranial node and the smallest nodes as well. So Again to Dr. Samir, Dr. Kuldeep from Ambala, what unique precautions must be taken during pediatric foreign air body removal? And let's say that the kid has aspirated a battery. How do you prevent the chemical reactions? How does airway anatomy differ from pediatric retrieval procedures? What complications can arise during a foreign body extraction?
So I think one of the major things is that for pediatric cases, the anatomy is very different. As you also mentioned, the glottis is a very narrow part. So typically, the challenges that occur is one, all the instruments are to be the smaller instruments that are generally required. There is higher chances of main stem bronchi or the tracheal obstruction in these cases, and care should be taken to actually extract the body out of the glottis very easily. Never try to maneuver it a lot around that. Certain things which the batteries, typically those the rounded batteries which are there, they can cause chemical pneumonitis for these patients. It's important to extract these carefully and quickly whenever you recognize these ones. And even metallic forceps may be useful for these cases. Never try to maneuver a lot around the glottis part, around the vocal cord. That can cause a lot of airway edema and actually cause asphyxia for these for the kids.
Yeah, true.
And finally, the complications are all the granulation tissues and airway edema, vocal cord edema. All of these can be encountered very easily in children.
Yeah, I think now you're going on to the ultra rapid mode because we still have a lot of questions left. So, to Dr. Virotam sir, Dr. Jijo from Trivandrum, what are the uses of different needle sizes? Quick comment, sir.
For core biopsy, you can be larger to 1921. For cytology, you can use 2122.
Yeah, and Dr. Sumit from Amritsar, what is the role of real-time imaging in TBNA to Dr. Vinod? Must be asking about EBUS.
So real-time imaging, it's asking for the EBUS.
I think EBUS should be anytime preferred over conventional if you have an access to it.
Yes,
Yeah, right. And from Dr. Balakrishna from Mysore to Dr. Jyoti, when should sedation and anesthesia be considered? I think you touched upon it
Yeah.
already. So again, Dr. Rishabh from Nashik, can TBNA be done in a patient with a T-tube?
Yeah, it can be done provided the T-tube size is large, but typically, T-tubes we end up putting a size 10 or 12. From that, passing your EBUS scope is usually challenging. Conventional TBNA may be done. So,
Yeah. And I think what you can essentially do is you pass it through the nose and
yeah.
then go and do the TBNA. No need to pass through the T-tube once you have a T-tube in place. And Dr. Kunal from Kanpur, again to Dr. Samir, when is rigid bronchoscopy preferred or flexible? I think we touched upon it.
We've discussed
Dr.
that.
Dharmendra from Mohali, warfarin with INR2. Would you stop when and what is absolutely contraindicated? To use Dr. Samir.
Yeah, so it is absolutely contraindicated maybe when you're dealing with certain other procedures such as tumor debulkings and all. For EBUS, not really. And you have to see why is it on. If the person has a pulmonary thromboembolism or some significant say valvular heart disease wherein it is there, I would like to bridge the patient with some other anticoagulant such as say heparin or maybe Clexane, low molecular weight heparins, and just hold one dose prior to it and then maybe do my procedure.
Yeah, and to Dr. Virotam sir, do cryoprobes play an important role in foreign body removal?
It's already discussed. Organic.
Yeah. And to Dr. Vinod sir, if a foreign body falls from the original site further, should the procedure be abandoned or it should be explored? Dr. Suresh from Vijayawada.
Original site?
If it goes down, should you still try to attempt it or you just abandon it and come out?
No, we have to remove it because and with some advanced procedure and with the advanced technology we can't.
Yeah, I think the foreign body is always a foreign body. You have to
Yes.
remove it because
Yes.
it can cause granulation. And to Dr. Samir again, Dr. Sultan from Mumbai, what factors determine whether TBNA or foreign body should be done in a flexible or rigid? Again answered. Dr. Matthew from Coimbatore, how should an airway perforation be managed? Again answered. Dr. Pushpendra from Jamshedpur, what is the approach for a suspected organic foreign body with surrounding granulation tissue? Dr. Jyoti, do you want to take it? If the foreign body has got a granulation tissue, what are the steps you would take?
So yeah, as already told in the lecture also, Dr. Sameer has already discussed whenever the granulation surrounds. So first we have to clear the granulation. We have to use a resid, or if we have a cryo, so we will try to remove the granulation and then we have to remove it. If the organic rounded body with
Yeah.
the surrounded by the granulation tissue, then the best tool is a cryo biopsy tool. Cryoprobe is a tool. We can use it for removing
Yeah.
this.
And try to avoid electrocautery as much as possible
Yeah,
because
APC should give, yeah.
it heals by fibrosis again. So to
Yes.
Dr. Veerotham sir, Dr. Pawan from Ghaziabad, what neck and mediastinal conditions make the TBNA extremely difficult or dangerous?
Medicinal should be avoided. Important thing is superior vena cava syndrome sometimes, very having
Yeah.
the SVC and the medicinal cyst, if you are having in the CT scan, you should avoid.
Yeah, very true. And to Dr. Samir, Dr. Ravindran from Trichy, okay, that we have answered already. Dr. Abhishek from Patna, explain in detail the jabbing versus suction versus slow pull technique for TBNA. When would you prefer a non-suction technique?
Yeah, so I think suction versus slow pull is different and jabbing is entirely different. Jabbing is for puncturing, entering the node, and which is that you push your needle out of the scope and with the needle only you just jab the mucosa and enter the lymph node. That's one. That is different with the piggyback wherein you move both the scope and the needle together. When we talk about suction and slow pull, suction is you apply a syringe, which is say maybe minus 20 50 cc, apply some negative pressure and allow for it to come out. Slow pull is you slow without the suction, you just slowly pull and allow for a capillary action for the sample to get aspirated into the needle. So these are the thing. Non-suction technique maybe when you have a very vascular node, but again, we generally use a suction because it can immediately identify whether you have, as Vishwesh also mentioned, you can identify the blood and stop right then
Yeah,
and
I
there.
think one last question we have before we call it a day to Dr. Jyoti. Dr. Anubhav from Pune, what is the maximum safe number of punctures through one bronchial wall, maybe through one pass? How
One
many
pass
how many
3 to
times should
one pass 10 to 12 times, we have 10 to 15 times somewhere is given. So I think one pass we have to puncture for the 10 to 12 times, we have
10
to
to
do
12
it.
times? Yeah, fair enough. So I think we had an exciting day of academic deliberation involving everything about conventional TBNA and foreign body. I hope we did justice to the topic provided, and thanks to IAB for continuing its academic march and the entire governing body of IAB for having given us this opportunity. I would like to thank my panelists, Dr. Virotham sir, Dr. Samir, Dr. Vinod, Dr. Jyoti, for patiently listening to all the questions and giving their expert insights. And I think if there are no further questions, we'll call it a day and have a great day. And hopefully, we meet for a next web meet soon. Thank you.
Thank you everyone.
Thank you, Dr. Vishweshan, for excellent.
Thank you.
Yeah, thank you Dr. Vishweshwaran for
Thank you, ma'am.
Thank you.
yeah.
On behalf of the IB, I am thankful to everyone, all the panelists, moderator, and the speaker, and the people who joined all over from the country. So the latest news week crossed more than 2,200 login today. And congratulations to IB and the people behind it. Thank you. Thank you
Yeah,
to all.
thank you.
Thank
Thank
you.
you. Good
Good
night.
night.
Good night,
Bye.
sir.
Good night,
Bye.
everyone. Good night.
Thank you, sir.